Now I'd like to invite Dr. Chavez to come. Dr. Ruben Chavez is a public health professor at the School of Medical Sciences, Autonomous University in Baja California. His research focuses on molecular epidemiology of HIV, and he'll talk about some of that work in the context of Tijuana, Mexico.
And it was a collaboration between UABC, the school where I teach, CIFAR, through Sanjay Mehta, and the Ministry of Health in Tijuana, at the HIV and STD clinic in Tijuana. So a little bit of facts. So the OMS tells us that around 36.9 million people are living with HIV around the world, and 14.9 million are under treatment. In Mexico, we have some numbers through Censida. It tells us that about 176,000 AIDS cases have been notified in the country, and that we have around 10,000 new cases just in the 2014, and in the state of Baja, it's around 7,000 and so cases. And in Tijuana, my own experience working with non-governmental agencies and the Ministry of Health, we know that we know of around 1,500 and 2,000 HIV cases, and we know that we have around 20 new cases a month in the city, just in Tijuana. And as you know, subtype C is the more prevalent HIV-1 subtype around the world, in Africa and Asia. And to concentrate on our continent, most of the studies that have been done around us have told us that subtype B is the most prevalent subtype in the Americas. Drug resistance, this report from the WHO that shows in red the countries that have around 5% to 15% levels of drug resistance to any drug class, and we have Mexico in red, and also some parts of South Africa and China and a little bit in Europe. And this picture that shows us that the correlation between the infiltration of antiretroviral therapy and the prevalence of resistance to NRTI medicines. And we can see in this picture that as countries or regions have more infiltration in medicine, their resistance mutations also get higher. So since in Tijuana and the whole country in Mexico, we just recently had introduction of full coverage of treatment to patients. The Ministry of Health now gives medications to the HIV population in Tijuana. But, so we expect to have a high rate of resistance in our city, especially in Tijuana. So that's why we decided to try to analyze it. The methods we use, we analyzed 120 subjects with a viral load over 1,000 copies per milliliter that were recruited at the HIV and STD clinic in Tijuana, Mexico. We applied the informed consent questionnaire and took a blood sample. The viral RNA was extracted and PCR amplified at UABC, and we had an applicant of 540 base pairs. Samples were sent to lab here in UCSD for sequencing, and we were able to sequence 81 of the 120 samples. The sequences were filtered, hand-curated, and subtyped using a Squill program, implemented in DataMonkey, and screened for drug-resistant mutations using the calibrated population-resistant tools by Stanford. And we also did a phylogenetic and network analysis of the sequences data to characterize the patterns of transmission. And phylogenetic trees were fair using maximum likelihood approach implemented by the program field. And this is what we found, some very interesting data. The mean viral load was 80,980 copies, and the CD4 count was 333 cells per microliter. 70% of the people were men, and the resting 30 were female. 62% of the people we analyzed were using drugs or had used drugs before. 60% of them had shared needles. And a high 70% of those people had been in jail for some time. 27% of the 81 participants had practiced sex work, and 41% of the people had been illegal at one time of their life in the U.S., and 67% of them have been deported. So the sexual preferences of the population we studied is that 36% were homosexual, 57% were heterosexual, and 7% were bisexual. About how they acquire HIV is, and the place where they acquire HIV is that 83% reported to have been diagnosed and acquired HIV in Mexico, and 17% here in the US in different cities. 52% of the people we sampled had antiretroviral treatment, and 66% reported to have abandoned it one time at least. And concerning their treatment, 63% were on their first cocktail of treatment, 18% were doing their second treatment, 13% were on their third, and the rest, 6% were on the fourth. And the subtypes we found, we know that subtype B is actually driven the infections in our city, but we also found some CRFs. We found 1.2% of CRF03. We found another 1.2 of CRF17, and 2.5% of the samples were CRF28, and 5% were CRF29. And 90.1% were subtype B. The drug-resistant mutations we found is that we have a total of 12.1% of the people presented more than one mutation, 6.7% presented mutation on NRTI, and 8.2% presented NRTI, and 3.4% presented both types of mutations. 30% of those 12.1% mutations were present on people who had never touched any medication or treatment, and 60% of those people have been illegal immigrants to the U.S. And this is the mutations we discovered in those samples, L71. You can see them right there. The conclusions are related to the goals of the study since we began it. It was to analyze a large number of samples in Tijuana. This was the first time we tried it. Evaluate the correlation between the drug resistance and the HIV risk factors in order to improve of our understandings of the HIV transmission dynamics in the city, and better design and target prevention and control strategies more efficiently in our city. This results support the hypothesis that the HIV epidemic in Mexico is taking different patterns of distribution that previously described. So this is the first time we have found, or I have seen on literature, that as an example, a lot of the people that have been analyzed and found resistance on them have been deported from the U.S. and have been illegals right here in this country. Also, the risk factor associated with HIV differ from the U.S. Epidemic, since they are related to the things that I was explaining before. Risk factors such as migration and drug addiction. So with this, we know that the HIV subtype V remains the main driver of the epidemic in Tijuana. But we now know, and we found that CRFs are emerging and changing the picture of the genetic structure we knew about HIV in Tijuana. Also, the mutations related to drug resistance we found suggest that the transmission of it could be occurring since we detected these people that never had any treatment with antiretrovirals, and they have these mutations, and that transmitted drug resistance could be affecting morbidity and mortality in Tijuana. We don't know that, but in the future, we should be studying that. And studies focusing on transmitted drug resistance will be very useful for fulfilling our aims to control the HIV epidemic in our country. And finally, I thank a lot for the UCSD CFR for the support through the NIH grant they gave us. I thank a lot David Smith for all the help he has always done, through Sanjay Mehta, Dr. Stephanie Strati for the help, and Patricia Gonzalez for helping us a lot in technical ways on the research, and Ignacio Caroline, who helped a lot too. And that's it.
Questions?
In the slide where you're showing the prevalence of drug resistance, you had a bar with 60% of the people who were immigrants or deported from the U.S. had drug resistance. Do you think that there's something related to deportation, or was that just a matter of a small sample size that percentage seems so big? Yeah, this one here. How many people was that 60% represent?
It's actually a small number of people, since we only had 80% and only 12% actually had mutations. But I think it's a matter of a small number of people in the participant in the research. But also experience tells me that it might really be a huge problem for Tijuana, because all these people have been in the U.S. where the antiretrovirals have a long history of implementation. They have been earlier here, and I think that maybe they are getting the resistance or the HIV resistance here, and then they get deported and they appear in Tijuana.
Yeah,
I
think that's
know that.
Right, I agree. I think that's a good point. It might be because of the fact that they're moving back and forth, they're having a harder time being consistent with their antiretroviral therapy, and that could be causing it. Thanks.
administration.
Thank you very much. I'd be very interested in knowing, among the drug-using population, what drugs are being used and how they use them. I think I noticed that you mentioned that there was very little sharing among the drug users, or at least by self-report. What are the drugs and what is the route of administration?
Well,
Do you know?
the most used drugs is heroin and crystal meth, cocaine, and a little bit of people use marijuana. But the drug they use the most is crystal meth and heroin. And
One injected or is it snorted?
yes, heroin, cocaine, and crystal meth can be injected. Yeah. And they share needles. That's another big trouble we have, because we have people with HIV drug resistance, and they are sharing needles. So we expect, if we don't control this, we expect the numbers to go higher.
Do you know anything about
I'm sorry,
availability, syringe and needle availability in Tijuana?
there's Cuete, I think is the name of the research project that UCSD and CFAR is doing in Tijuana, in exchanging old needles for new needles. But still in Tijuana, the system is not ready, too much ready for that, because we have seen this trouble. In Tijuana, if you have a needle, even if you don't use heroin, and if a cop gets you, you go to jail just for having a small syringe. So and we have to do a lot of work before trying to change the ideas of the people.
I have one more question about that. Is it possible to buy needles and syringes without a prescription?
Yes, it is. You can buy marijuana.
Anything, right.
Yeah.
It was interesting to hear the resistance mutations that are transmissible. And I was wondering if you were able to separate these mutations that you identified into those that can be transmitted, as opposed to those that actually reduce the ability of the virus to initiate a new infection, and therefore they're only observed in treated patients, but not in naive patients.
I can't understand the question.
So, given the virus, some mutations may reduce its ability to start a new infection. So they're not transmissible. And others are transmissible, and you identify those.
Well, this is just a small advance, it's just describing what we found.
Right.
Right now we're working on we're also doing trying to cluster the viruses, the sequences we have, to find lines of infection between the population. So we need to investigate that.
Yeah, so it would be interesting to try and separate these mutations into kind of transmissible and non-transmissible. Yeah.
Hello, congratulations, Roman. I'm really proud that you make it this day to talk about your research. I'm Patricia Gonzalez, and I'm the director of the Cuete Phase 4. And to answer to Dr. Friedman, there's a lack of syringe exchange. There's very few syringe exchange programs in Tijuana now. There's a shortage, and the people that are using drugs are really limited on access to those syringes. After the Global Fund, the access diminished a lot. Thank you. And we as Del Cuete, we're not allowed to exchange, to give them syringes because of our funding. So we can't do that. Thank you.
Thank you, Father.